It's a pleasure to be here. It's my favorite meeting every other year to go to, so I appreciate it. As we know, the PAO has been shown to improve pain and function for symptomatic dysplasia, and many of these patients have labral tears and interarticular pathology, and perhaps failure to address this interarticular pathology may lead to some early failures. Hip arthroscopy has been utilized more and more to evaluate the interarticular pathology and treat it at the time of a PAO. We know it's been used as an adjuvant. It's getting more routine, including labral repair. But the outcomes of labral repair or refixation versus not fixing the labrum at the time of a PAO is unknown. So we wanted to compare patient characteristics and functional outcome scores associated with combined arthroscopic labral refixation and PAO with results that just had an isolated periacetabular osteotomy. All patients with symptomatic dysplasia undergoing a PAO in our hip preservation registry over a 4-year period that's prospectively collected data were included. It was a retrospective cohort design, and we had a minimum 6-month follow-up off the second surgery or the final surgery. So if they had a second side surgery, we reset them to time 0. So we had a mean of 24 months and with a range of 11 to 46 months, and this left us with 2 cohorts. The PAO alone is 53 patients and 63 hips. The PAO scope is 19 patients and 21 hips. If you look at this time period, we had 130 hips that could be involved, and about 30% of them either didn't do pre or post-op follow-ups or had a second side surgery. That left us with 89 hips that were split. The indications at our Center for Scope PAO are symptoms suggestive of labral pathology, but more a labral tear where the labrum appears to be detached from the acetabular rim on the MRI, as you can see here. Isolated labral intrasubstance tears without detachment weren't indicated for the procedure, just PAO only, and no patient in the PAO only group had a labral tear with rim detachment. Here's an example of a patient with hip dysplasia, a labral tear off the rim. You can see the interarticular pathology that was repaired. The technique, I do it with, I don't do the arthroscopy myself. I use Dr. Kelly and our other arthroscopists at our center, where they first place on the traction table. They do a minimum capsulorrhaphy, or just very small opening of the capsule so it doesn't affect the approach for the PAO, labral refixation or other interarticular things that need to be addressed on the acetabular side, and no femoral osteoplasty is done. That would be done through the open portion of the PAO. And then we transfer to the radiolucent table for the PAO. We check preoperative measures, intraoperative measures, and postoperative measures, the Harris Hip score, outcome score, and internet IHOT 33. The demographic results, the only difference was age. You can see here there's a slightly older age in the Scope PAO group with a mean of 28 years versus the PAO group. There was no difference in sex, BMI, prior hip surgery, range of motion, or presence of a provocative test on exam. We had increased acetabular anaversion in the Scope PAO group at 3 o'clock, so perhaps that puts more tension or stress on the labrum, but there was no difference in the 2 groups with lateral C angle, anterior C angle, tonus grade, femoral version, or alpha angle. So on physical exam, there was no difference in range of motion, impingement signs, or apprehension between the 2 groups, and the preoperative radiographic, as I mentioned, showed increased acetabular anaversion. And of those patients that didn't have the Scope PAO, 66% of them had labral pathology but not detached on MRI. Concurrent surgery done at the times, other open interventions were osteochondroplasty and AIS debridement. These numbers are a little lower than in general, than a lot of centers. Other arthroscopic interventions were labral teres debridement and some loose body removal. There was no difference in the PAO surgical time between the 2 groups. The arthroscopy increased the total surgical time under anesthesia, or how we do anesthesia, by a mean of 45 minutes, so a range of 25 to 60 minutes. There was no difference in the radiographic correction and no difference in the complications between the 2 groups. Here's a general view of the outcome scores, and I'll just talk about the differences. All absolute scores improved in both groups at both 6 months and 1 year, with the percent, as you can see on the right, reaching minimal important change. If you look at the difference between the 2 groups with functional outcome scores, the change in the IHOT 33 from baseline to 1 year was a little greater in the Scope PAO group than the PAO only group, and the change in the HOOS sports subset at 1 year was greater in the SCOPE PAO group versus the PAO group. The modified Harris-Hip score and the HOOS ADL, there was no difference at 6 months and 1 year and greater than 1 year. So in conclusions, on their patient characteristics, they tended to be a little older, more increased anaversion, and similar baseline scores in those that had the SCOPE and periacetabular osteotomy with a detached labrum. It was safe. It did not affect our surgical correction or approach, and there was no difference in the complications. Again, there was a change in 2 of the scores, the IHOT 33 at 1 year and the sports subscore, but not the modified Harris-Hip score. But we do need a larger cohort and longer follow-up. The indications for hip arthroscopy is based on our center-specific use of MRI of what we consider to be an unstable labrum, and in all but, I think, 5 cases it was. And currently, we're looking into doing a prospective randomized study to see, to try to take out any bias. Thank you.